Hello, dear friends. Welcome back. I am Dr.Jothydev Kesavadev. When we are entering into the new era of insulin pump therapy, it is essential that we should be reviewing the story of success and failures and the multiple challenges with insulin pump therapy. Most of them are not specific to our country, but in general. And in this very brief lecture, I'll be sharing our personal experiences and the lessons that we have learned. So I have nothing to disclose. So when did I start using insulin pumps? I first got exposed to insulin pump therapy, and that was in 2003, in the year 2003, when I was undergoing endocrinology training at the prestigious Mayo Clinic at Minnesota, USA. So back in India, in the year 2004, this is Adrian Good, and this is Ramakrishna, who is still very active with insulin pump promotion. Adrian Good was the guy, was the friend who launched insulin pumps in our country in India. And that was in 2004, 2005. So if we could focus on this picture, you can see the insulin pump, and you can also see the first ever CGM, that was a continuous glucose monitoring gold, sitting on top of the table over there. Of course, it is a very, very old picture, and that is when it all started. But soon we realized the multiple challenges when more and more patients are using the device. And this is one of those episodes. Of course, this can happen, and this is happening all over the world. This patient has sustained multiple sports-related injuries, and he is there at the emergency to dress his wounds. Look at the response of the sister. The sister has realized that the doctor is probably not at all aware of the functionalities of an insulin pump, because insulin pump is not included in the MBBS or in the MD syllabus. And the ignorance is translated to anger and anxiety. And he's expressing this as anger. Throw the bloody equipment away, or else I will not take care of her wounds. And this happens all over the world. And that is the reason why this scenario is now included in the guidelines on use of technologies in diabetes. Another scenario. And this is a doctor who is calling me, and this is an urgent call. It's an urgent call for deployment of an insulin pump. But alas, look at the patient. Her father is bedridden with multiple diabetes complications, including amputation of a leg. Of course, we can start some of these newer devices, the AIDs, but conventionally, insulin pumps are meant for those who are physically and intellectually very active. Insulin pumps are meant for improving the quality of life of already active individuals, both with type 1 and with type 2 diabetes. And this is an advanced delivery gadget and has got superiority and far more benefits when compared to the ordinary insulin syringes, when compared to the conventional insulin pens. These are much more superior, but we need to go by the criteria. So there were multiple challenges during the initial decade of starting insulin pumps in our country. The biggest challenge was to convince the senior doctors in our own specialties and in allied specialties on why insulin pumps are different. Why is it superior? What is emerging evidence? What are the recommendations all over the world? So it was a necessity rather to have more evidence generated. And some of them are even making controversial comments that they will require a surgery for deployment of another device, as if insulin pumps can produce infections all over the abdomen. It can produce hypoglycemia and death. Whereas in reality, insulin pumps will drastically reduce the cost of treating the avoidable and deadly complications of diabetes. That is the truth. If you are using insulin pumps in the right candidate at the right time, this is the device which is going to prevent all those avoidable deadly complications. That is the truth. So what is the solution? How to convince the doctors in allied specialties? Of course, remember what I am presenting is history. Now the scenario has changed. And this is what we did. We kept on conducting programs, the continuing medical education programs. But again, the challenge was the senior-most doctors, the opinion makers, they're very busy and may not be attending the continuing medical education programs. So this is one sort of those programs. Way back in 2006, in the middle is Dr. Munir, the celebrity from Kerala. He was a minister at that time. He himself is an insulin pump user, and we have the Christopher Saudek. So Christopher Saudek is no more with us. And we do similar programs. We did similar programs multiple times for many years for doctors as well as for the patients. If somebody is asking you, when did real-time glucose sensing, when was it started in India? It is not in 2019 or 2020. It started way back in 2007 when we started using the sensor augmented insulin pumps in our country. So this was a time via radio frequency, the pump will sense the interstitial glucose values and these numbers will get displayed on the insulin pump screen. So this is 170, which keeps on changing once in every 5 minutes. And that was phenomenal. We together as a group from all over the country, the key opinion leaders from all over the country, the top names, we decided that we should be urgently publishing the insulin pump guidelines for India. It was rather a legal necessity for the doctors, for the patients, for the policy makers to be aware of how we have to select the patients, the inclusion criteria, how you have to exclude the patients, the exclusion criteria, why insulin pumps are necessary in a subset of patients with type 1 and type 2, not for everybody. Everyone may not require it, but for a subset, it is going to prevent death. It is going to prevent the deadly consequences of diabetes. And how this can, even though an expensive gadget, it can drastically result in reducing the cost of future diabetes complications, for future cost of treating the diabetes complications. In 2012, that was the time when we deployed the first ever VO insulin pump in our clinic. And this is how the insulin pumps started automating from stage 1 of automation onwards, when the insulin pump will stop the delivery of insulin when there is a hypoglycemia. Of course, that was the beginning of automated insulin delivery devices. So how do you define a closed loop system? How do you define the success of an artificial pancreas? So an artificial pancreas or an automated insulin delivery device will have 3 vital components. One is an advanced insulin pump over here, and then you have an advanced glucose sensing device. So we have the continuous glucose sensor over there. And this is now much more advanced compared to the earlier generation CGM devices. So the third device is probably the most important one, the control algorithm. So we have the multiple algorithms which will help automate the delivery of insulin. 6 years ago, we witnessed the launch of the third level of automation, and that was 640G, the first generation artificial pancreas. And that came out with a predictive low glucose suspend mechanism. 670G, of course, was capable of automating the delivery of basal, but it was not launched in our country. So how do you define the success of a technology? Leave alone diabetes technologies in general. How can you define the success of a technology among the human beings? The success of a technology depends on how easy to learn, how easy to use, and how easy it is to carry around with you, and how easy it is to troubleshoot during the day or during the night if something happens. Is it easy to troubleshoot or not? And the perfect examples will be the popularity of a smartphone, the touch phone, the popularity of Freestyle Libre as a continuous glucose monitoring device. So if you ask me a question, over the past more than a decade, the insulin pumps as a treatment modality in India hasn't been a success. Of course, it is now being used by thousands of patients, but in a majority, it has been a failure. It has been a failure because the pumps at those times were not that easy to use. It were not that easy to learn, and it was not that easy to troubleshoot. And there were challenges connecting the devices to the CGM, the glucose meter, and so on. And I would like to go deeper into some of these aspects. So when you are selecting a candidate for insulin pump therapy, they should fulfill the essential criteria. They should have some passion with the use of technologies, and they should be comfortable carrying the devices with them with realistic expectations. So with realistic expectations, and they should be willing to monitor the glucose values. They should be willing to use the continuous glucose sensor. They should be willing to download the data and to communicate with the care team, willing to follow with the diabetes nurse. And they should also have the adequate financial resources to support. Because apart from buying the pump, that is the upfront cost, there are recurrent expenses which are involved. Lack of family support, I would say, is the single most important factor which will decide the long-term success with insulin pump therapy or with any diabetes management, no matter how sound the treatment of all the technology is. This can be effective and successful only if there is family support, and that is the most vital component. Persons with diabetes, PWD, and their care partners, and for the geriatric population, they need to receive education, repeated levels of education, repeated sessions, both about management of diabetes in general and also about the use of diabetes technologies. And if you get back to the inclusion criteria once again, those who are eligible for an insulin pump, if they are late in initiating the insulin pump, if they are, say, 5 or 6 years late in initiating insulin pump, these are the candidates with a long history of uncontrolled diabetes, or with history of low glucose, or with history of high glucose, or these are the candidates with multiple complications. And these are the candidates likely to have depression, anxiety, and might require psychosocial support in addition. So this you should never forget. They may not be having a normal cognitive function as well. And these are one of the reasons why the insulin pumps can malfunction. Human error, very common. And some of these patients are having poor mathematical skills. So robust education is necessary. And you have to re-evaluate. And we as physicians should be capable of identifying those subjects who are at a higher risk of committing a human error. Let me now share with you one of my own personal experiences, a real life case. And this is the history of Sanil. He was diagnosed of type 1 diabetes 25 years ago. He survived. He survived with minimal complications. And he met me first time in the year 2018 at 51 years. And he was already on an insulin pump for the last 8 years. He has upgraded the pump multiple times during the 8 years. But very sad, on inquiring, we found he is having uncontrolled diabetes on an average more than 300 milligrams per deciliter. He had absolutely no idea on how to program the basal. The pump was not programmed at all. He was simply bolusing without a basal. This poor guy has developed all the possible diabetes complications: bilateral retinopathy, nephropathy, coronary artery disease, intervention, and 6 months ago, he had a COVID, and post-COVID, now he is on dialysis three times every week. So we inquired what really happened, what actually happened with him. He believed that deploying an insulin pump as an expensive gadget is going to be a one-stop solution for diabetes, which is wrong. That was only a beginning. He didn't know that. He never went back to that physician who advised insulin pump. And I asked his family, why are you not supporting? And they said that he is abnormal. He is having an irritant behavior. He's anxious. He's angry all the time. And hence, they are not interfering with his therapy. Very sad story. Very, very sad story. And these are the patients who will require a support from a psychologist or from a psychiatrist, in addition to a diabetologist and the care team. And if you ask me, are insulin pumps safe? My answer is, if you're not capable of using this gadget, don't use it. Because among all the devices used for treatment of diabetes by the patient, insulin pumps are responsible for the maximal number of errors and loss of life. So what are the viable solutions, the possible solutions? We as doctors or certified diabetes educators or dietitians, we need to spend ample time not only to identify the candidate, but also to discuss with them the multitude of benefits and the demerits if they are not careful in using the gadgets. And it's very essential that the hospital should have an infrastructure. The hospital should also have the team work along with the doctor to support the patients 24/7. And most of the successful users are the young doctors. And we need to ensure continuing caregiver support. And I will request all the doctors and everyone who is listening to me that these are the newer technologies, much advanced, and the benefits of these technologies should never be denied for those who are eligible and for those who are affordable or those who can support. Even for the poor patients, we should be discussing with them. They should be given the option that this is available in our country, and they might find out a solution from somewhere to use it. Even we are supporting hundreds of patients with similar gadgets, hundreds of economically challenged patients who are really eligible. So what is the next big thing which is happening in diabetes in our country? 780G is already available in India. This is the stage 4 of automation of automated insulin delivery devices. So when compared to any other available insulin pump anywhere in the world, this is much more advanced. When the glucose is trending high, the insulin pump or 780G will automatically increase the dose of delivery of insulin. When the glucose is trending low, then the insulin delivery will gradually decline proportionate to the sensor glucose values in response to the algorithm. And if you are forgetting the bolus delivery before a meal, even the bolus can be automatically calculated and delivered by the gadget. So it is amazing. It is truly amazing thanks to the control algorithms such as the PID, the model predictive control, the fuzzy logic, and so on. And this is the complete package with the new 780G, which comes with the Guardian sensor, the Guardian Link 3 transmitter, the Accu-Check Gate glucose meter, and this gets connected to your mobile phone, the CareLink, which is supported by Medtronic, and so on. So these are some of the terminologies: the SMARTGUARD shield, the sensor glucose, the active insulin, which you can manipulate, and if you can bring it down, you can probably further increase the time in range. So this is designed, this gadget is designed to maximize the time which is spent between 70 and 180 milligrams per deciliter. So we have the auto basal, auto correction, both in response to the sensor glucose values, that is currently the Guardian sensor 3, that is GS3 sensor. Auto correction stands for the bolus corrections. So how do you define the PID or the proportional integral derivative, which is responsible for the merits with this algorithm or the control algorithm? So proportional, and that is how far the sensor glucose, the distance from the set target. Integral, the length, how long the sensor glucose has been away from the target. Derivative is again the calculation of time, how rapidly the sensor glucose has been changing. And this estimates the total insulin. The algorithm, remember, does not learn the time of the day patterns or trends. And the click of the right arrow, you can assess, you can have the display over the pump screen, the TIR, the time below range, and the time above range. Amazing, amazing. And this is one of the recent studies comparing the sensor augmented pump PLGS with advanced hybrid closed loop system. And when you look into the depths of the details of the TIR which has been accomplished, it is as close to 80%, with the new advanced hybrid closed loop systems. So I would say that this translates to almost 80% success in automating or closing the loop with the new systems. And this is the current South Asian recommendations for the TIR and the frequency of repeating the TIR and the AGP report. If the TBR is less than 1%, and if the TER is more than 90%, probably you need to repeat CGM only once in 6 months, especially in type 2 diabetes. But in case the TBR is more than 4%, or the time below range or the time below 70 milligrams per deciliter is more than 5%, you need to repeat CGM more frequently. And that is based on your clinical judgment, where you need to customize based on the patient's requirements. And it is absolutely essential that we need to incorporate TIR in addition to hemoglobin A1C in our daily clinical practice. And this is the evolution. So this is a recent review from our group, the evolution of insulin delivery devices, when we are commemorating 100 years of insulin delivery, the first insulin injection, starting from the insulin pumps devised by Arnold Kadish in 1963. Then you have the first do-it-yourself artificial pancreas, the patient-devised systems capable of even more than 95% TIR, not approved, not regulated. And that has been in place since 2015 and now becoming more and more popular. And even the ADA in the 2022 clinical practice recommendations have referred to the do-it-yourself artificial pancreas. And so happy, glad to share with you the news that the American Diabetes Association has referred to one of our own original research from our center referring to the DIY artificial pancreas. This is my concluding remark. Insulin pumps are like acquiring an expensive set of books. If you don't have the time to read, if you don't have the time to learn, then you're never going to reap the benefits of these newer gadgets. Thank you. Thank you very much for being with me and listening to this lecture on advanced delivery gadgets for delivering insulin. So thank you very much and bye-bye.